Good afternoon, everyone. Welcome to today's class. In today's class, we will have 3 hours, almost 3 hours together. In the first hour, I will go through the presentation, go through my presentation with the topic focusing on the different tools used for diagnostic testing. Now, we know this is a literature evaluation research design class. So in the second hour, Dr. Sharma will help me to assign you into different groups. We will go through the group assignment together. And in the third hour, we will have you finish some individual assignment. Before going to today's presentation, I want to share with you one simple clinical scenarios. As a future pharmacist, you will have opportunities to work with clinicians in hospitals in terms of integrating the results of diagnostic testings. In one scenario, there is a patient, 35 years old female, consulting with her OBGYN about whether she has gestational hypertension and other symptoms because she's 35 years old being pregnant. To answer her question, obviously the doctor will perform some diagnostic testing to find out whether the patient has this particular disease. The possible results of the diagnostic testing can be the results is positive, showing that yes, the patient has this gestational hypertension. The results can also be negative. No, it means no, the patient do not have the disease. But really, in terms of answer whether the patient has or has not the disease, it's also determined by how accuracy or how good the diagnostic testing results can be. So in this lecture, we will learn together, we're gonna learn some essential indicators to measure the accuracy of a certain diagnostic test. And these measures will allow us as healthcare professionals to determine the appropriateness of the diagnostic tools. In today's agenda, we will first talk about some terminologies surrounding the diagnostic testing. This include what is accuracy, what is sensitivity, what is specificity, and what is positive predictive value and negative predictive values. And followed by that, we will discuss different methods for us to use sensitivity and specificity. Specifically, we will go through 2 active learnings. One is which I believe Dr. Sharma has shared with you, 1 pages of active learnings. So we will I will walk you through these 2 active learnings. And lastly, we will briefly discuss about the reservoir operating characteristic curves. Firstly, the terminology around clinical diagnostic testing include, as you see here, accuracy, sensitivity, specificity, positive predictive value, negative predictive value. And all these measures help us to answer one question: how will the test help us to discriminate between those who are healthy and those who are not healthy, and help us to really interpret the probability of having the COVID-19 if the test is positive, or the probability of not having COVID-19 if the test is negative. As I just mentioned, in the clinical practice, when the patient goes through the diagnostic testing, the possible results can be negative results, means the patient does not have the disease, or it can be the positive results. It means the patient have the disease. But like I said, it really depends on how good, how accurate a diagnostic test tool is. Because even if the patients have the positive diagnostic results, they can still, patient may not have the disease. This is the false positive, right? If the test result is negative, but the patient may still have the disease, this is called false negative. Well, ideally, we want as many true positive or as many true negative as possible. This means the test results is accurate. True positive means that the test results is positive and the patient have the disease. And true negative means when the test results is negative and the patient does not have the disease. But in reality, they can be false positive. That means the test result is positive, but the patient actually does not have the disease. The testing tools incorrectly identify patients with the disease. And this could also happen when the test result is negative, but the patients actually have the disease. This means that the diagnostic tools incorrectly identify the patients is disease-free. I really like these 2x2 tables. This will help you better understand the full concept, true positive, true negative, and false positive, false negative. First of all, on these 2x2 tables, on your left side, you will see the possible test results. It can be positive test results. It can also be negative test results. On the top of these 2x2 tables, you have the actual disease status of the patients. It can be the presence of the disease and the absence of the disease. Now, if the test results is positive and the patients really has the COVID-19, for example, this cell is the true positive cell. Next, if the test result is negative, the patient is disease-free, the patient is healthy, the cell is called true negative. In reality, there will also be the scenario called false positive. It means that the test results is positive, but the patient's is actually COVID-19 free. This is called false positive. It may also happen when the test results is negative, but the patient has COVID-19. It's called false negative. Overall, you can see we can use this 2x2 table to demonstrate relationship between the possible test results and patient's true disease status. And I really want you to visually remember this 2x2 table because we will have exercise together to calculate the true positive, to calculate the number in each cells. What is accuracy? Accuracy is overall measure of the diagnostic test in terms of differentiating between those having the disease versus those who are healthy. It is composed, mathematically, when we want to calculate accuracy, we involve the components of both true positive, true negative, false positive, false negative. As you see on my right hand, accuracy is defined as the total sum of true positive plus true negative divided by all the 4 possible testing results. It's the overall measure of how well the test can differentiate those having the disease versus those who are not having the disease. Now, I want to mention that the accuracy, when we talk about accuracy, we're actually talking about both the sensitivity and specificity. What's the difference? Now, look at these 2x2 tables. I want to draw your attention firstly to the column of condition positive. Okay, draw your attention to the column condition positive. Sensitivity means the proportion of the true positive, the proportion of the test correctly identify those having the disease among the population who have the disease. Okay, so the sensitivity equals the total number of true positive divided by the total number of true positive plus false negative. In other words, sensitivity means that among the population who have COVID-19, what are the proportion of the test results showing them with being tested positive, right? Of course, among those who have the COVID-19, the test results may show that it's positive test. The test result may also show it's a negative results, right? And the sensitivity means that the proportion among those with COVID-19, the proportion of the test of them being tested positive, the proportion of them being tested positive. On the contrary, specificity means that when we talk about specificity, I want to draw your attention to the column of those with condition negative. Specificity means that among those who are healthy population, what proportion of them being tested negative? So specificity is defined as the total number of true negative divided by the sum of true negative plus false positive. Question here. Okay. As mentioned, sensitivity is the ability to find true positive. It means that among those who are among the population with COVID-19, what is the probability of them being tested positive? Right? To calculate sensitivity, we calculate the proportion of true positive out of all cases of true positive plus false negative. The denominator is the entire population actually having the disease. Sensitivity really means the how sensitive the test is able to detect the disease among the population with the disease. On the contrary, specificity means that among the population who are disease-free, how specifically this test can help to detect the true healthy population. It is defined as the proportion of true negative out of all cases of true negative plus false positive. The denominator is the population who are disease-free. Specificity means that ability of test to detect healthy population. What is the positive predictive value, negative predictive value? Well, the PPV and MPV takes a different perspective here. The PPV, to calculate PPV, I want to draw your attention to the rows of the test positive rows. The PPV equals the true positive divided by true positive plus false positive. It means that among all the possible positive results, what proportion of them really having the condition, right? In contrast, MPV, negative positive value, means that among all the possible negative test results, what proportion of them are the true negatives. So if you think about it in this way, sensitivity and specificity, they respectively means that among those having the disease, what are the how sensitive the test is able to detect the true disease patients, whereas specificity means that among this healthy population, how specifically this test can help you to identify the healthy people, right? It has specificity, sensitivity. It only deals with how accuracy, how good your testing tool is. It has nothing to do with the prevalence of the disease. But both the PPV and MPV, it is not only deals with the how good your testing tool is, it also has relationship with the prevalence of the disease. Now, as mentioned, PPV means that among the those with the positive results, what is the proportion of true positive? And then MPV means that the given all the negative results, what proportion of cases who are actually do not have the condition. Both the sensitivity and specificity, they cannot alone to determine the value of diagnostic tools. We will show you in the coming slides that in order to determine the value of the diagnostic testings, we need other informations as well. And we need the pre-test probabilities, and we also need post-test probabilities. Now, I want to kind of pause here a little bit for you to digest what we have learned about the concept of sensitivity, specificity, and PPV and MPV through one examples of 2x2 table. So please take out active learning that we have distributed, that Dr. Sharma has distributed to you at the beginning of the class. Now, through these examples, we will together calculate the numbers in each cells. But before that, I will give you some information. The patients with aseptic meningitis may be infected with Lyme disease. And this is especially true if they live in an area with high prevalence for Lyme disease. Let us give you some information here. Let's say the incidence of Lyme disease among the Mississippians presenting with aseptic meningitis is 19 out of 100. Let's assume that we have diagnostic tools, that this diagnostic tools has a sensitivity of 81% and a specificity of 96%. Now, we have this information given to you. We provide you the epidemiological data of the incidence of the disease. We also provide you the specificity and sensitivities of these diagnostic tools. I want you to calculate based on what you have learned about the sensitivity specificity to calculate the true positive value, number of true positives, number of true negatives, and false positive, false negatives. Let's work this example together. Now, let's create a 2x2 table. As mentioned in the 2x2 tables, on the left side, we have possible testing results. On the top side, we have the actual disease status, diseased and disease-free. Suppose we have a total number of 10,000 Mississippi residents here. So the total here is 10,000. And based on that, we have the total number of disease population with Lyme disease population. This is 300, right? Because we already give you pre-test probability of the disease. The incidence of the disease per 100 people is 13. Okay, and this also gives us that they are 8,700 disease-free population here. Now, let's first calculate true positive. Remember, we mentioned the sensitivity equals true positive. Sensitivity is the fraction of the fraction of true positive divided by the entire population of those who have the disease. In other words, among those who have the disease, what are the proportion of them being tested positive? Hence, we can calculate the true positive. True positive equals the sensitivity multiply the total number of those who have the disease. We obtain the true positive as 1,053. Right? The total number of those who have the disease is 3,000. Multiply the 81%, which is the sensitivity. The next we can obtain is this cell is called false negative. False negative equals the total number of those who have the disease minus true positive. And then next, we know the specificity, and the specificity equals the true negative divided by the total number of those who are healthy population, right? Specificity equals true negative divided by those who are healthy. With that, we know that true negative equals the total number of those who are healthy multiply the specificity. This gives us 8,352 true negative here. What about this false positive? False positive equals the total number of those who are healthy minus the true negative. Okay, so through the information, based on the information of pre-test incidence of the disease and the information of sensitivity and specificity of these testing tools, we obtain this detailed 2x2 table, including the true positive, true negative, false positive, false negative in the 2x2 tables. And then we can also calculate all the possible positive results and all the possible negative results. And from there, I want us to further calculate PPV and MPV. Remember, the PPV equals the true positive divided by all the positive results, right? And then the MPV equals the true negative divided by all the negative results. So I want to pause here to see if any question. Now we have talked about these diagnostic tool testing measures. I also want to mention another concept is likelihood ratios. Likelihood ratios, if you notice, it is a ratio, means that there is a denominator, there is a numerator. It means probability of person with condition has a certain test results divided by the probability of person without condition has certain test results. It can be the positive likelihood ratio, or it can be negative likelihood ratio. If it is positive likelihood ratio, it means the probability of a positive test results among the patient, among the population, among the persons with disease, divided by the probability of positive results in the persons who do not have the disease. It equals the sensitivity divided by 1 minus specificity. Think about that. The probability of positive test in the person with the disease is the sensitivity, right? That's the numerator. And what is probability of positive test among the persons who do not have disease? It's 1 minus specificity, right? Because specificity is the probability of negative testing among the person who do not have the disease. So the denominator for the positive likelihood ratio is 1 minus specificity. On the contrast, negative likelihood ratio means the probability of a negative test in the persons with the disease divided by the probability of negative test among the person who do not have the disease. Think about it. The probability of negative test in person with the disease is 1 minus sensitivity, right? Because sensitivity is probability. Remember that sensitivity is probability of positive test in person with the disease. If we want to obtain probability of negative test in person with the disease, it's going to be 1 minus sensitivity. And obviously the denominator is the specificity, because we already mentioned specificity is the probability of negative tests among the persons without the disease. I also want to mention that if we want to choose a test to rule in disease, we want to choose larger likelihood, positive likelihood ratio test. On the contrast, if you want to choose a test to rule out disease, we would rather choose a likelihood ratio, smaller likelihood ratio, negative likelihood ratio test. Now, this is one example. If you want to choose a diagnostic test, let me ask you in this way. We have in one study, we have three testing tools. It can be CRP, it can be procline cytokine, or white blood cell count. What types of likelihood ratio tests you're gonna choose if you want to rule in infection? Well, as we mentioned, if we want to rule in infection, we want to choose these ones with largest positive likelihood ratio test. Then this is the procalcitonin, right? If we want to rule out infection, we would choose the ones with smallest negative likelihood ratio test. This is the CRP. I also want to talk about one important theorem. It's called Bayesian theorem. The Bayesian theorem is a very important tool for clinicians or healthcare researchers to identify conditional probabilities by relating one conditional probability with another conditional probability. Let me talk a little bit about what is conditional probability. In the COVID-19 area, you may ask, if you get a COVID-19 testings, given your test results is positive, what is the true probability of you having COVID-19? This is called conditional probability. Or given the test results of cancer test is, given the testing results of mammogram is positive, what is likelihood of being cancer-free? Or given the COVID-19 testing results is negative, what is likelihood of having COVID-19? All this, if you notice here, this is called conditional probabilities. The probability of disease-free and the probability of having the disease conditional upon the results of testing, positive testing results, conditional upon the negative testing result. This is called conditional probabilities. And the Bayes theorem is a very powerful tool that help us to calculate these conditional probabilities based on additional information we have from the testing tools. We always write the Bayes theorem in this equation. If you notice that on your left hand is one conditional probability. On your right hand, you have one conditional probability. And you also have the generic probability of event A and the um, the information or the evidence B here. We can say like this, given the test, given the information B, what is the probability of having event A? That is equals to the probability of event B conditional on event A multiply the prior knowledge of probability of event A divided by the probability of event B. Now, I know it sounds a little bit unfamiliar, so I want to use one particular example to walk you through how great this Bayesian theory is to help you calculate, for example, the probability of having COVID-19 given the testing results is positive. Now, I translate this Bayesian theory using this one vivid example. Here you can see that on your left hand, the probability of having COVID-19 given the testing results is positive. It is equals the probability of having the positive testing results given one has COVID-19 multiplied probability of having COVID-19 among the entire population divided the probability of the all the having the positive test results. So I want also mention that in your denominator, having the positive testing results can be divided into two scenarios. One scenario is having the COVID-19 having the disease. One scenario is having the disease and being tested positive, and the other scenario is do not have the disease and also having the positive test results. So your denominator can be written as two parts. One part is having the COVID-19 and being tested positive. And the other part is do not have COVID-19, but still being tested positive, right? This is combination of, it's possible positive results. It's combination of the true positive, and this is false positive, right? Okay, now let's say there is one example. If the testing tool for COVID-19 has 95% sensitivity and 99 specificity, and we also know that the prevalence of the COVID-19 disease is 1% among the entire population. So I would like us to use Bayesian theory to calculate the probability of COVID-19 giving one test result is positive. See here, I want us to use Bayesian theory to calculate one conditional probabilities based on the information of the sensitivity specificity of the testing tools, as well as the pre-test knowledge about the prevalence of the disease. So in order to obtain this, we need to solve this, we need to identify the numbers of the each components on this equation here. First of all, there is a probability of COVID. What is the probability of having COVID in this population? That is 1%, right? Okay, and the next, what is the probability of being tested positive given the population of having COVID-19? So in other words, what is the that is I want you to think about these 2x2 tables. What is probability of being tested positive given the population having the COVID? This concept is what is sensitivity, right? This concept is sensitivity, right? And then we can solve this component here. So next, what is probability of being tested positive given population COVID disease free? Remember, specificity is the probability of being tested negative given the population of disease free. So the probability of being tested positive given the population of COVID free is 1 minus specificity. Lastly, what is probability of not having the disease in the population? It's 1 minus the prevalence of the disease. With all this, we can solve the equation here. So we can use to summarize, we can use this information to calculate the probability of having COVID disease given the testing results is positive. What did you get? Okay, to summarize, the Bayesian theorem relates one conditional probability to another conditional probability. It helps us to identify the probability of having an event based on the prior knowledge of conditions associated with the event. The information we have seen in the prior example is that we can understand the conditional probability of having the COVID-19 given the testing result is positive based on information of how well the testing tool is. It is namely the sensitivity and specificity, and also based on information of the prevalence of the disease, the epidemiological data of this disease. With all that, this is all I got for the Bayesian theorem. And there's another article if you're interested to talk a little bit more about the use of Bayesian theorems in the clinical trials. Okay. Lastly, I want to talk about these ROC curves. It's called receiver operating characteristic curves. These ROC curves, if you notice, it has x-axis and a y-axis. It's a relationship between the false positive rate and the true positive rate. So on your x-axis, you have false positive rate, which is equals 1 minus sensitive specificity. On your y-axis, you have the sensitivity, which is the true positive rate on your y-axis. And the ROC curve, it shows the trade-off between the sensitivity and specificity. Ideally, you want your diagnostic tool to have a higher ROC curve. That is it has a very it has the and the ROC curve can provide visually provide graphical representation of diagnostic abilities. It helps determine the cutoff point, which optimize sensitivity and specificity, and can help us to compare tests. For example, on your right hand, if you have the 4 diagnostic tools, diagnostic testing A, testing B, testing C, and testing D. Each has its own ROC curves. Which one would you choose for the optimal test? Of course, obviously gonna choose the one with the higher AUROC, that is one associated with higher area under ROC curve. The higher the ROC, AUC means the better the predict performance of the test. Usually it must be more than 80%. Curve A is perfect test and curve D is a useless test. And in one study, we have the white blood cell count to identify bacterial infection in neonatals. And if we have different thresholds, we obtain different the sensitivity specificity. And for each one set of them, we can obtain a one ROC curve. And finally, we can compare multiple testing using the ROC curves. And we can see that different tests have different AUROC results. Because it's the different ROC curves. And obviously we will choose the one with the we will choose the test that is associated, that corresponds to the highest AUROC. To summarize, we have learned about different measures of to evaluate the accuracy of testing. This includes sensitivity and specificity. Remember, we mentioned sensitivity is how sensitive the test is able to detect the true disease people among the population with the disease. Specificity denotes that how specific this test is able to detect the disease-free or the healthy people among those who are healthy people. So sensitivity means this equals the true positive divided by the true positive plus false positive plus false negative. And specificity equals the true negative divided by true negative plus false positive. So please go back to the 2x2 table to help you visually memorize this concept. An ROC curve, as we mentioned, is a relationship between true positive rate against the false positive rate. In other words, it's a relationship between the true positive rate against the 1 minus the specificity. And at each threshold, we can obtain different ROC curves. And we always would like to choose the ones with the higher area under the ROC curves. This is so far we have for this literature and journal, literature evaluation journal clubs. And I would like to take any question if you have. If not, we will go to the next section, is we will briefly talk about Aquido tools before we go through some examples, the group assignment and individual assignment.